So I have been given a task to discuss about molecular, prevention of cancer. Most of us, talk about cancer, very often, and we talk about prevention, screening. This is one of the most important area, but unfortunately, this also becomes the most ignored area, and we oncologists are one of the party to it. We talk very high about prevention, screening. This is the most important area which can drive future of cancer care in all low resource income countries, including India. But when it comes to show our efforts in taking the initiative at ground level, we reasonably fail in that. So I have no disclosure for this presentation. So let me. So cancer incidence in India is on rise like any other country. It is on rising. And with the bad part is that almost, 50%, near to 50% people die of it. And India-centric cancer are mostly preventable. If you talk about the Government of India data, oral cancer, breast cancer, and cervical cancer, that India-centric cancer, where government has a concrete policy framework to define about the prevention and screening strategies. But it needs much more attention because of the high mortality in view of advanced stage at presentation. So we have progressed so much related to genetic, molecular, and immune basis of cancer. And now, whatever the therapy has been given to any part of the world, in India, it's available. So now we are just going for the genetic testing, genetic counseling, using the high level of immunotherapy. So we have progressed so much. So prevention is still a challenge. And if prevention, your conventional prevention is a challenge, it is so difficult to think about the molecular and immune prevention in an era where we are using the not the standard, whatever the feasible for cancer prevention in India. Suppose I will give an example like breast cancer. Standard is mammography, but in India, whatever is advised by Government of India is the clinical breast examination because of the cost and the logistic concerns. We know that dual co-testing with HPV DNA and pap test is a standard if you talk about the cervical cancer. But in India and other low resource countries, it is now we are doing it, VIA, which is visual inspection with acetic acid, and the major concern is the cost and the logistic. So this immune prevention and molecular prevention, this concept is very promising, but still the cost is a big factor, and how to implement as a population-based approach is it's beyond imagination, and I nobody can answer to this question at this point of time. So molecular, what do you mean by molecular prevention? So it has a wide area. It encompasses traditional chemopreventive agents as well as vaccination and therapeutic approaches to cancer, which is many predisposing cancer, which is causing cancer. So you just treat them with the therapeutic approaches so that the conversion from the pre-malignant lesion to cancer can be avoided. So we all know about vaccine. Many of us are well aware about cervical cancer, hepatitis B virus vaccine, and it is the one of the best kind of chemo prevention. Unfortunately, HPV vaccine is not part of our national vaccination program, although it is advisable by all the committee of the Indian Pediatric, Indian Association of Pediatrics. So these are the two vaccines probably known to everybody. I will discuss this whole thing in detail, how this is a part of the molecular prevention in cancer. So we all have heard about, chemo prevention in breast cancer, and, tamoxifen and raloxifene has been used in various trials to see that in the high risk cases, I think that the people who are more than average risk for develop the invasive breast cancer, they have shown the benefit by using tamoxifen and raloxifene as a chemopreventive measures. And various trials like STAR trial discuss about that. NSABP has already given a good result when you use in the people who has more than average risk to develop the invasive breast cancer. And the use of tamoxifen and raloxifene, there was decrease in the risk to develop for the invasive breast cancer. So coming to the most important, which is human papilloma virus, which is caused by various subtypes, but most important subtypes which causes the major burden of the disease is the HPV 16 and 18. It was previously understood that yes, cervical cancer is a major risk for cervical cancer. Human papilloma virus infection is, counted as a major, risk factors. But apart from cervical cancer, HPV also causes vulval cancer, vaginal cancer, anal canal cancer, penile cancers, and many are in the Western country. Now the statistics related to the oropharyngeal cancer has been changed, and now there is a 200 to 300% rise in number of oropharyngeal cases, and the cause is only one, which is human papilloma virus. So there are three kind of vaccine which is available for the cervical cancer and anything which is against HPV. Cervarix is a bivalent vaccine which is used against 16 and 18. If you talk about the quadrivalent vaccine, which is Gardasil, which gives protection against 6, 11, 16, and 18, then newly approved, FDA approved vaccine is Gardasil 9, which apart from giving protection against 6, 11, 16, and 18, it also gives protection against 31, 33, 45, 52, and 58. So it is the most important vaccine which gives protection against 9 types of the HPV. So if you have an option to take a vaccine, it is preferred that you should go for the Gardasil 9, which gives the maximum protection against cervical cancer and other cancer which is caused by HPV. Photodynamic therapy, we all know that there is a high-grade dysplasia, in Barrett's esophagus, which might convert into the carcinoma esophagus. In the lower esophagus, because of the gastroesophageal reflex, it is seen, and photodynamic therapy can help you to ablate the high-grade dysplasia, so it can prevent the further damage to the mucosa, and it can help you to prevent the Barrett esophagus and subsequently carcinoma esophagus. Celecoxib is used with the people who has familial adenomatous polyposis, and it causes a reduction in the number of adenomatous carcinoma, adenomatous polyp, and subsequently it decreases the risk for the colorectal cancer. BCG, which is used for the treatment of the urinary bladder, so the male and female with carcinoma in situ of the gallbladder, probably BCG, intravesical use of BCG decreases the risk for that. Valrubicin and fluorouracil. There are many agents which are used for the pre-malignant lesion of the skin, which is multiple actinic keratosis. So if you use that, topical uses can prevent the occurrence of cancer in the longer run. So these are the agent which is used for the actinic keratosis cases: diclofenac sodium, iminoglobulin, mandibulate. So these are the uses. You can use it topically, and it can prevent skin cancer occurrence. So we all know that viruses causes infection, and infection in the longer run may cause the cancer. So hepatitis B and C virus, we all are well aware that yes, it causes hepatocellular carcinoma, and you can have the intervention like hepatitis B vaccine, interferon therapy, and nucleoside analog, which can prevent the occurrence of hepatocellular carcinoma if you are infected with the hepatitis B and C virus. Human immunodeficiency syndrome, apart from causing, acquired immunodeficiency syndrome, it also causes Kaposi sarcoma and non-Hodgkin's lymphoma. So if you are an antiretroviral therapy, you can prevent the occurrence of Kaposi sarcoma and the non-Hodgkin's lymphoma. Helicobacter pylori is a responsible agent for the gastric cancer. And if you start with the, antibiotic regime and the triple or quadruple therapy with pantoprazole, antibiotic combination, you can prevent the, gastric or stomach cancer occurrence. Schistosomiasis is a risk factor for the bladder cancer. So if you treat the patient with anti-schistosomial agents, probably you can prevent the occurrence of bladder cancer. So what is in the news for many days? biomarkers. We always talk about biomarkers. There are many biomarkers which is used for prognosis to, see the response of the treatment. Because of their unspecific nature, we are unable to use it at the preventive modality or as screening. So development or validation of promising biomarkers and effective technology for pre-neoplastic lesion to know that early detection and risk reduction is important. For that, we need to develop of knowledge base and informatics, because sometimes you get the information, but it is very important to decode those information. For that, you should have a good bioinformatics team, those who can, just decode the information and reach to a valuable conclusion. So development of new high through output technology, either refinement of the existing technology to certain, yes, this kind of technology will sure short give you the right idea about the preventive approaches when you are using it. So, so biomarkers, how it is used, it can be used for the risk and early cancer detection. It can be used for predicting progression of pre-neoplastic, pre-cancers to the aggressive cancers. Biomolecular technology can be used for early detection of cancer, like we are talking about the high-end sciences where we talk about genomics, proteomics, metabolomics, and the nanotechnology. We can use it for the early detection of cancer, genetic predisposition, and identify high-risk population, which are the another area where you need early intervention and early detection of cancer because they are higher at risk. So validation of promising molecular detection approaches in the clinical setting and population-based trials so that we can know the actual effect. So to save more lives, we need effective methods, because it is rightly said, it costs 1 billion, to have a single cancer medication through the regulatory pipeline. So if we use fraction of that, new diagnostic to spot cancers in the earlier stages ultimately could save many of the lives. And the full life, cancer, for the disease like cancer in low resource setup like India, we need to have such kind of intervention where we can detect it early and where we need less of logistic. So risk assessment, early detection to guide therapy is very important in today's context. So you see this graph from 1994 to 2003. You see there are increase in the number of biomarkers, but you see the number of approvals they have been given by the FDA as a plasma protein markers. It has come down from 1994 to 2003. So when collaboration doesn't take place, probably we are just running on one way. There is no there is no way to come back. So we don't need to, walk on this path where there's only one way. We need to collaborate and we need to make this path more, visible and the more meaningful. So state of science and biomarker research, there are more than 40,000 papers in cancer biomarkers every year, but around only 4,000 to 5,000 on biomarkers are for early detection, diagnosis, and the prognosis. 99% of the biomarker study claim that their sensitivity is more than 90% and specificity, but it comes to the approval from the FDA, probably very, very few biomarkers get through that. So what are the probable reasons? Maybe biology of early diseases, it may be not fully explored to detect a suitable biomarkers. There may be differences in the analytical techniques. There may be difference in the statistical methods. There may be incomplete protocol reporting. There may be lack of appropriate specimen and reagents. There may be variation in interpretation, biases, chance, and overfitting. So in view of that, there is strongly a need of cost-effective biomarkers, which we can use by the simple blood test or any other, fluid which is accessible and which are easy to use. There are, things about the circulatory free DNA, which is making news nowadays, but still today's we can't take any of these biomarkers as an effective screening method for any of the cancers. There are certain, markers which is your whole genome and other things, but it is not feasible to, but yes, you can do it. Somebody is interested, they just go for it. But ultimately, it's not a cost-effective meaning. And in a country like India, where we are struggling to implement, normal screening methodology like, oral visual examination, clinical wrist examination, and visual inspection with acetic acid, and it is so challenging. We can't even think of implementing such biomarkers, which are not even a cost-effective modality. So we need to work hard, and probably we need to think something in India-centric with high specificity and sensitivity, so that we cannot overdiagnose somebody, because if you overdiagnose, there are mental trauma related to the cancer diagnosis. And if you underdiagnose it, it is again not a good modality that people have gone for the test, but they have not yet accurately done. So, take home message: the heterogeneity and complexity of advanced cancer strongly suggests rationale for enhanced focus on molecular prevention as a priority to reduce the person burden of cancer. Molecular prevention encompasses, as I said, the traditional chemotherapeutic agent, vaccination, and therapeutic approaches to cancer predisposing condition. More than 10 agents approved by US FDA for the treatment of pre-cancer lesion. Mainly, it is in terms of skin cancer and the breast cancer. So we need to progress more in the development and evaluation of molecular preventive markers. So in order for preventive molecular prevention to be fully realized as an effective, there are challenges, and probably we need to work on those challenges. Thank you so much, sir, for this.